that bond of I've been there, I do actually understand. It's not just empathy. I've been in your shoes. It builds a connection of trust where folks are more willing to follow your model and your steps because they really believe in you and they start to trust in you.
Welcome to our 6th episode of Season 2 of the 98%, Life After Prison, a show dedicated to the roughly 20,000 incarcerated people in North Carolina who are released back into our communities each year, often with little or no support. I'm Judy Van Wyk.
And I'm April Barber Scales. At the top of the show, you heard the voice of Darrell Clayton describing the importance of community health workers to the FIT program, formerly in transitions. The FIT program provides health care for returning citizens who suffer from a chronic illness, mental illness, and or substance use disorder. In addition to connecting people to a primary care provider, FIT's community health workers, who are themselves formerly incarcerated, work directly with each client to connect them to any support services they may need, including behavioral health or substance abuse therapy.
Dr. Evan Ashkin, a physician in UNC's Department of Family Medicine, launched the FIT program in 2017 in coordination with Lincoln Community Health Center and the Durham Public Health Department. A clinic in Orange County soon followed, and today the FIT program has clinics in 7 North Carolina counties. Let's begin our story about North Carolina FIT by hearing from its founder, Dr. Evan Ashkin.
So FIT stands for the Formerly Incarcerated Transition Program, and it is about helping people re-enter from incarceration. So people coming from prison and jail and trying to do comprehensive re-entry for those folks. But a big difference with FIT is the connection to healthcare, which unfortunately has been lacking in many re-entry programs, not just in North Carolina, but throughout the U.S.
So what was it that inspired you to start FIT?
So I'm a family physician. And for most of my career, I have worked in different settings where the populations that I served were predominantly marginalized, minoritized in different ways. You know, sadly, I actually did not really pay attention to the impact of a history of incarceration or involvement in the criminal legal system for many, many years. It was about 10 or 12 years ago when I had helped establish what we called the underserved track in the family medicine residency at UNC, which was based at a federally qualified health center in Prospect Hill, which is sort of north of Hillsborough near the Virginia border and actually quite rural. And that population serves a lot of communities of color, and those communities have been disproportionately impacted by incarceration. And finally, I started paying attention to the connection between being impacted by the criminal legal system and then the utter destruction of most things in your life and chaos that occur. But one thing that really struck me was the void people fall into post-release as far as getting any essential health services. It started under UNC Family Medicine because that's where I still am. I'm a professor of family medicine there and have been able to, it's been very advantageous to have this within the UNC system as well because we're part of the state and it allows direct contracting with state agencies to do this kind of work as well. But the model, the reason why the model is so successful, and I am a complete devotee of these 2 women who started what's called the Transitions Clinic Network in the Bay Area of California. They started the work in about 2006, 2008. And they did something very unique. They actually went and talked to people impacted. So they started the model of hiring people that were formerly incarcerated and training them as community health workers, and then embedding those community health workers in community health centers which, traditionally across the U.S. are the best place for that kind of care because we have embedded case managers, oftentimes integrated behavioral health services, and serve a predominantly underserved or uninsured population, which clearly is the case for this population as well.
What exactly is the role of the community health workers?
Yeah, so, the FIT program is the community health workers. Also, when you look at the evidence, why does this program work? And I want to state that the Transitions Clinic Network folks have extensively studied this model, where people have fewer hospitalizations, fewer emergency room utilization, fewer days of incarceration, fewer parole and probation violations, and that it's cost effective. And there's really we're actually quite unique that way. There are wonderful one-off programs all over the country, but for an actual program that is been organized in this way and then expanded, this is really the only model in the country that is extensive like this and has been studied to show its benefit. So the role of the community health worker is to hopefully engage even prior to release, because people are at very high risk for poor outcomes even in the first 2 weeks post-release, to have comprehensive reentry planning based on what the client needs, not what we think they need, but what they need, and then to help them in all those things. So we try not to be siloed. If it means they need an ID and that means they have to get their birth certificate from Ohio, we'll help them do that. And then we'll take them down to DSS to apply for food stamps or Medicaid. Let's go to the food bank. So it's not referrals. It's very hands-on, making sure they get to the appointment, setting up the appointment. The FIT program, we recognize that in our state, we were going to have to pay for the sliding scale fee at the health centers and for meds because we didn't expand Medicaid up until December. So everyone was pretty much uninsured. So the community health worker helps that because we now have relationships with all of our clinics where we cover those costs. So it's because the community health workers have this lived experience, and that is what makes the difference, because they are able to quickly gain rapport and trust. Because no matter how well-meaning, I'm a white, you can't see me, guys, I'm a 63-year-old white male who represents everything bad that has probably happened, especially to our people of color who have been in the criminal legal system. But the community health workers, and almost all our community health workers actually are people of color, are able to create that rapport and say, hey, I know we have to help with housing and employment and transportation and an ID, but let's not forget about your health.
You said that they're really high risk in the first 2 weeks of getting out. Why is that?
Yeah, so this initial work was done by Ingrid Binswanger and actually published in JAMA a number of years ago, showing that in the first 2 weeks post-release from incarceration, there's a 12 times greater risk of death just in those first 2 weeks in the general population. And it's sadly because of violence, drug overdose, chronic medical conditions, suicide. But you may know that very sadly, because the opioid epidemic, which is now the number one cause of death for people under 50 in the U.S., all people coming out of the prison system in North Carolina, and this is North Carolina data, are at 50 times the risk of death in the first 2 weeks post-release in the general population because of drug overdose.
Let's talk about substance use disorder as a chronic disease, not unlike hypertension or diabetes.
There are many reasons why people turn to mind-altering substances. And at first, you're using the drugs to achieve a different state of mind. And it's not immediate that it becomes a problem. And for a number of people, it never does become a problem. But there are sadly a large percentage of people that when they start using recreational substances, they feel better than they've ever felt before because they suffered from a neurobiologic disturbance that could be related to trauma, other kinds of issues, or just pure genetic issues with deficiencies of neurotransmitters. Now, as you start using these drugs, they release large amounts of dopamine. And this is one of the things that makes us feel good in life. I mean, dopamine is the thing that drives almost all of our behaviors. So if you're regularly using drugs like this and your brain is seeing these high amounts of dopamine regularly, that sadly changes your brain chemistry and changes your experience, honestly, of reality, because you are over time fatiguing your brain's ability to make dopamine, and these smaller releases no longer have an impact. So you are being driven to continually have these larger releases through drugs like methamphetamine, cocaine, opioids to achieve that dopamine state. Over time, and this is especially true with opioids, because of the withdrawal issues, people who are regularly using opioids oftentimes get almost no euphoric effects, or if they do, it is very brief. And what they're actually trying to do is not feel like they're dying. Because without dopamine, if your brain gets so fatigued and you can't make it, so let's say 10 was that amazing day, right? 5 is what it takes to get out of bed. But if your brain now can only make 1 or 2 dopamine, you feel like you're dying. So this is what drives so much behavior when we have so much trouble understanding, oh my God, how could someone steal from their parents? How could they take their grandmother's cancer, pain medications? I mean, that's almost incomprehensible, right? If you don't understand what changes happen to the brain. But if you're unable to make dopamine at all because of the use, and now you're totally dependent, your brain is diseased, doesn't make this, and you will feel like you're dying, and sadly do things that will wind you up in prison, and also with terrible judgment and stigma to get your drug so you don't feel like you're dying. So it becomes a disease. It becomes a brain issue without being able to make dopamine, and it takes a long time to recover. And this has been the failure of abstinence programs, is they're telling people that they're deficient, they should just stop, but it doesn't acknowledge or treat the issue that they feel absolutely horrible during that period of time. And even when they get on a drug like Suboxone, what we're doing is we're allowing the brain to heal by they're no longer using the illicit opioids. But it doesn't mean the brain is then able to make dopamine at a regular state the next day at all. It can take months or even longer. So people still have to suffer through, they're not feeling like they're dying because the buprenorphine in the Suboxone is helping with that. But they still can have very little joy in their life because their brain is still unable to make this dopamine to give them joy. And I'll give you an example. I had a client who we got him on Suboxone, and he stayed on it, wasn't using any drugs, but his life was really empty. And I was like, just hang in there. And he came in with a huge smile on his face about 6 months into treatment. And he was like, oh my God, Dr. Ashkin, I took my kids to the park, and my son ran up to me beaming and hugged my legs and looked up at me, and I felt joy.
In general, in your experience, how does the prison experience, how does being in prison affect people's health?
Prison systems were not set up to be healthcare centers, right? And we have so failed in our society that they are, you probably know, the number one provider of mental health treatment now in the U.S. is our carceral system, which was not built for that. Same with substance use disorder, number one treatment provider, not set up for that. They should be able to provide adequate basic medical care for chronic disease, but again, they are poorly funded. And I can tell you it is incredibly hard to hire people to work in the prisons providing health care. So it is way too easy to blame the prison system for this problem. There are many ways where incarceration, that toxic environment, the limited healthcare services, the struggle that any carceral system has in staffing healthcare, having adequate nursing, physicians, nurse practitioners, PAs, are really enormous. And that is a societal failure, that we do not care about people once we're incarcerated, and we put this burden on a prison system that has not been designed to do this properly.
We now have Medicaid expansion. Will that cover incarcerated people as well as people after they get out?
Yeah, so very interesting. When the Medicaid laws were first written, and I'm not sure of the politics of this, but they excluded anybody who was incarcerated. So what has happened in the U.S. since Medicaid started is, even if you had Medicaid, when you were incarcerated in a jail or a prison, at some point your Medicaid was either suspended or terminated. And the prison system or jail was on the hook, and is on the hook, for paying for that care. Fortunately, this has been recognized to be a huge failure and barrier, and something that has perpetuated racial health inequities in the U.S. So there is now something called an 1115 waiver, where states can apply to have Medicaid turned on 90 days prior to release. And our state happily is applying for this 1115 waiver to turn Medicaid on 90 days before release. And we're thrilled, because this will allow us to get our community health workers inside 90 days before, make contact, start talking about, what their reentry plan is going to be, housing, all this stuff, but very importantly, get their medical records, understand what clinic they're going to go to, who they're going to see, what, appointments they're going to need, and get that all done prior to release, so there's not this gap in care.
What do you think the most important thing you've learned doing this work?
I think the hardest lesson was to understand the utter absence of this discussion within the House of Medicine, and how all these, really incredibly well-meaning people who are very interested in healthy communities, and this is what systemic racism is all about, that this was just invisible, and just understanding the depth of what leads to that kind of ignorance, and how we could have failed so utterly in, extending our belief that every person counts and every person deserves good health care and support, and how we stopped at the doors of prisons and jails that was a very hard lesson to learn.
Dr. Ashkin says he has no trouble recruiting doctors working in community health clinics. They're enthusiastic about the FIT program. What limits his ability to expand the program is finding the money to support community health workers who are so vital to the program. And with Medicaid expansion, that becomes even more important, because there are going to be so many more people returning home from prison who qualify for health insurance. April, you know Dr. Ashkin. Can you tell us about your connection to FIT?
Well, I was diagnosed in 2000 with multiple sclerosis. And as we know, prison health care is not the greatest. And the one thing that I needed when I got out was someone specific. So Dr. Ashkin connected me with an MS specialist, and that has been a big help with me remaining healthy, just adjusting my medicine, because I was on the same medicine for 22 years. And medicine has improved by then, and what I used to take was no longer working for me. So I was able to adjust my medicine and get the help that I needed.
Well, from my perspective, the medication must be working, because you have more energy than anyone I know, especially with MS. And Dr. Ashkin, isn't he also your primary care physician?
Yeah, he's my primary care physician, even when, if I haven't had checkups in a while, or if I've gotten maybe some unfavorable results, or just need a second opinion or whatever. He always reaches out to me, and even before I reach out to him, he's always readily available. So I really appreciate that about Dr. Ashkin.
Yeah. Next, we're going to hear from Tommy Green. We were introduced to Tommy in an earlier episode when he talked about how his company SWIT, Success While in Transition, supports returning citizens in their transition back into society. Tommy's full-time day job is as the lead community health worker in Orange County. What does it mean to be a community health worker?
So I think the best way to describe what a community health worker is, we're like where social workers meet the community. We kind of like bridge the gap between their medical staff and them. We're like the big brother, big sister that they can rely on. We say, hey, this doctor has your best interests at heart. Listen to him, give him a chance. We're the best people to follow up after they see the doctor, to reassure that you still have that person that you can relate to on your team, by your side, walking you through your medication regimens, your mental health regimens, your substance abuse treatment regimens.
So how many of your clients struggle with substance use disorder?
Probably somewhere around anywhere from about, I would say, 65 to 80%. We have a high, that's the thing. That was the unique thing about this program too. You know, we started it off focused on chronic conditions all around the board, right? And then we considered substance use disorder as a chronic condition, right? And that's actually kind of up in the air in some circles. You know, so everybody in the healthcare field doesn't consider substance use as a chronic condition. But the unique thing about it is, again, once we got started, we were seeing so many cases of people that had substance use issues. We offer MAT, which is medical assisted treatment, at the clinic that we see them at, which is Piedmont Health Services in Chapel Hill. And yeah, again, it's a high prevalence of substance abuse in this population of people.
There's also a lot of mental health issues. Can you talk about that for a minute?
Absolutely. A lot of mental health issues, diagnosed and undiagnosed. You know, in my opinion, anybody that's done a significant amount of time is going to come home with no less than PTSD, right? And unfortunately, we're not taught to recognize that in ourselves. So that's why that's one of the ones that's like the biggest one that's misdiagnosed or undiagnosed. And a lot of times too, guys won't admit to certain things inside because of the treatment they will receive. So that's another way that guys are not getting the help that they need inside. And then they bring those same problems or issues rather out here. And that's, again, another person that's undiagnosed. That's one thing that actually the FIT program is helping identify as well. You know, we get these guys in and, you know, me not being an expert, but Dr. Ashkin recognizes certain signs, certain symptoms, and then he can make the recommendation or the diagnosis to help them get some treatment.
So what would you say the biggest challenges of your job are?
Housing is first and foremost the biggest challenge. We struggle finding them housing, hands down. I think the second problem is sometimes keeping the clients engaged. We see a lot of guys that'll come out, maybe make their first appointment, maybe not, and we never see them again. We consider it lost to follow up. And then also too, you know, with our substance abuse clients, people that are battling substance abuse or whatever or whatnot, they are the ones that I think we struggle with the most, and we have the biggest issues with keeping them engaged. But those three things I think are the top biggest hurdles for us to overcome. I think the biggest misconception people have about this population of people, or formerly incarcerated people, is that if you have a job, a car, and a house or a place to stay, any one of those three things, but mostly if you at least have a job, that you're okay, that you're going to be all right. And that's not always the case. With doing what we do, sometimes we push getting your meds together first before we push trying to find a job. Sometimes we'll push making sure you're okay mentally. Go get an evaluation or get checked out mentally before you go out to the work field. You know, it's so many other things that's more important than that these people have to focus on, have to make sure it's okay and it's all right before they step out into those other big responsibilities. Because getting a job, maintaining the job is a big responsibility. You don't want someone out there working for you that hasn't dealt with some of the trauma that they brought with them from prison. Could be a ticking time bomb. You know, a lot of us got in there overnight or in the blink of an eye, basically fast and rushing. None of us never really took the time to weigh out the things that we were doing, weigh out the decisions we were making, so on and so forth. So now that you get this second chance, why not take your time? Slow down. Speeding is what got you in there.
How do you work with Evan Ashkin? How does that relationship work?
So Evan Ashkin, that's my homeboy. That's my homie. I know you're gonna laugh when you hear this. So me and the guy that work, that's the community health worker for the Orange County Health Department now, we always joke that we kind of have a leg up because not only is Dr. Ashkin the director of the program, of the total program, he's also our primary care provider in Orange County. So I always joke, you remember the hair club for men joke, not only is he the client, he's the president. So with that being said, we have a very close relationship. We see him every week in clinic on Wednesdays. We stay on the phone with him about different clients, so on and so forth. And yes, he is the primary care provider for all of our clients in Orange County.
What do you think the most important thing you've learned in the work that you've done?
The most important thing I've learned in the work that I've done is patience. Patience. Everybody's not going to get it. Sometimes they're going to get it late. I've seen clients. One of the ones that I would mark lost to follow up. They show up a couple times, disappear for weeks, months, a few times, even years, and they came back and got back in the program, doing well now. So just patience and and never take it too personal because, again, I was formerly incarcerated myself. The people that I serve are my peers. So sometimes it's hard not to get too attached, not to take some of the pain and the anguish that they feel when something's not going right for them. And then it's very easily to take that home, So I had to learn, my mental health and my self-care is really important. You're dealing with real people. You're dealing with real life situations. Like it's hard not to take somebody home with you sometimes or not feel the frustration there. Cause I was there. I was just like every client I've ever served. Came home, no direction, didn't know how I was gonna get it together, had a plan. I stuck to it, had a plan, it worked. But it don't always work. And it didn't always work in the beginning. I had the door slammed in my face. I don't know how many times. I got good jobs, got in, thought I was going to prove myself. Couple weeks later, record check come back. I'm fired. Back to ground zero. I've put it all on the line for a job before thinking I'm good. Couple weeks later, fired, back to ground zero. That happened numerous times. You know how frustrating it is? If I was a person that battled substance abuse, I probably would have been using myself after all that. But thank God, I don't have those struggles. But I can sympathize with the ones that do.
I worked with Tommy for about a year at the reentry house in Hillsborough that he and William Elmore oversee. That experience really opened my eyes to the health problems that people deal with coming out of prison, especially the struggle with substance use disorder. Guys would be doing really well for weeks, sometimes months. And then suddenly one night, they'd miss curfew, and sometimes that would be the last we'd see of them. Or they'd get picked up by the cops. There was this one guy who insisted that as long as he was good, by which he meant he read his Bible and he said his prayers enough, he could beat his addiction to alcohol. So when he fell off the wagon, he fell hard. He got himself kicked out of the house and taken back to rehab.
I work at Freedom House Recovery Center as a peer support specialist. So I deal with people that are in recovery from substance use disorder, mental health issues, and after incarceration. I see a lot about how addiction plays a role in this. Once, I have some, most of my clients are doing well, but sometimes they fall off the wagon, quote unquote. They end up in detox and they have to start over. So addiction is one of those things that you might not be able to beat at one time. You might have to fall off the wagon to get back on the horse again.
Yeah, I think that falling off the wagon is part of recovery and that people should expect that. Yeah, it is a disease and it can be treated. And too often it's just stigmatized.
Mm-hmm. Yes, I totally agree.
In our final interview, we'll talk to Darrell Clayton, a community health worker who helped Dr. Ashkin establish his first FIT clinic at Lincoln Community Health Center. Darrell now works for FIT's parent company, TCN, teaching community health workers all over the country. Let's listen to Darrell describe his work.
My name is Darrell Clayton. I'm a community health worker and the lead community health worker for Transitions Clinic Network, based out of San Francisco, California.
Tell us more about TCN and your role.
Okay. Yeah, so TCN, again, is Transitions Clinic Network. And, they have 28, 30 sites across the state of California. Yeah, they do phenomenal work. And my role is I'm actually the trainer, the community health worker trainer. So I train curriculums, I train different trauma-informed practices, just different trainings that I offer. I allow space for one-on-one, and that's on a national scale. So I've been able to use my experience from working with FIT to support the whole country with community health workers, and I'm excited.
What did you learn from your time in prison that has prepared you for a job as a community health worker?
I think just learning more about myself and addressing whole health wellness. That wasn't the first time that I was in prison. And, I asked myself what made me go back. And I never addressed, honestly, some of my substance use, some of my mental health situations. And I did that this next time. And I got a work release job when I was at Hillsborough at the end of my sentence, actually working through Freedom House. So I was placed right around working and caring for people with substance use disorder and mental health. And I just started my career in peer support. So it was almost like it was destined. When you first come home from prison, you're faced with multiple barriers, from transportation to housing to just having money, and then the family dynamics, trying to get reacclimated. So there's a lot on your plate. And a lot of times what you'll do is you'll put your health on the back burner because you got a lot of other things you have to eat. You have to have a shelter. So we take that away and we show you on the flip side of that, using community health workers, formerly incarcerated people, as community health workers. We help to model that the whole life change, being healthy and being able to see the doctor and addressing your needs and trusting healthcare and just building that bond again, because a lot of folks come home with no insurance. Usually the biggest challenges is specialty needs. So anything outside of basic healthcare, we've been able to address things like Hep C, but then when you have complications where you need specialty care, it's very hard to afford that. And FIT is, we work with donations and grants, and Evan does the best he can to keep us afloat, but we can't pay for specialty doctor care. It's just too expensive. So trying to find resources to connect to get those paid for uninsured folks is probably the biggest challenge.
What does North Carolina need to really provide that health care for people coming out of prison?
I think we need to establish more community health workers, peer support specialists, and folks with these certificates and these trainings, because what they learn in these trainings is not only about themselves, but they learn how to engage and work with other people. That's a difficult skill set for some. And then you have the comparability of, I've actually have the lived experience. So now you get a few skills and learn how to engage people so you don't intentionally hurt them. You're only going to help them. And we can employ these people throughout the state.
If you could wave a magic wand and change one thing about the carceral system, what would that be?
If I could wave a magic wand, we'd be able to take that felony conviction off of my record. Because now, whether I'm 15 years home, married with my children and my dogs and living a great life and not bothering anybody, I still pay for things that I did when I was a teenager. Felonies 25 years ago. And my homeowner's insurance was almost doubled because of that. So closing on a house turned into a headache because of my conviction. And that should not have put a damper on my greatest day of my life, potentially.
Is there anything else that you want to say that I've left out?
No, I love you, Evan Ashkin. Yeah, Evan's a great person. He and I, we still go when we speak to the residents, the young doctors at Duke and UNC, and we come in and we talk about the work that we're doing and how Evan has employed someone who was formerly incarcerated. And we introduce this to these residents. They've learned all about the medicine and all their doctoral. Well, you have to learn about people and how to treat people. And when they come in because they're with the prison or they're with the detention center and they bring them into your ERs and they bring them into your centers, treat them like people because they are. And we get a chance to spread that message early to the residents before they graduate. And so me and Evan have been on a little tour going around and speaking. And yeah, that's my guy. I'm really excited about working with him.
You know, we've been talking about the serious healthcare needs among returning citizens in North Carolina. But at the same time, North Carolina is second only to California when it comes to providing healthcare for formerly incarcerated people. And it has to be said that since the beginning, the FIT program has been able to rely on the support of North Carolina's Department of Corrections. They have a contract with FIT, and they support 6 full-time community health workers, and that's important.
We may be doing well compared to other states, but 7 FIT clinics in 100 counties means there's a lot more need out there. We should have 100 instead of 7. Hopefully, the expansion of Medicaid will encourage more funding for FIT's community health workers.
I agree. Totally true. You know, Dr. Ashkin talked about how he's witnessed the damage that mass incarceration has done to the Black community.
It's definitely impactful. There are disparities in our country between Black and white and even people of color. And the only real way to address the healthcare disparities is to end mass incarceration, provide more resources before they get out, and connect them to the resources once they're out.
Yeah. Well, that's our show for today and our last show of the season. We're going to take a short break, and then we're going to start working on new episodes for Season 3 of the 98% Life After Prison. And we welcome your ideas.
If you'd like to share your story ideas with us or anything else, you can email us at 98%.lifeafterprison@gmail.com. That's 98% the number .lifeafterprison@gmail.com. In the meantime, we plan to post bonus episodes with interviews from a variety of people working to reform our criminal justice system. So stay tuned.